Atrial fibrillation's a disease that can be thought of as a fraying of the wiring of the heart that leads to short-circuiting that causes the heart to beat rapidly and irregularly. And that's not efficient. And that inefficiency can cause symptoms in people: short-windedness, lightheadedness, chest discomfort, palpitation, fatigue. Symptoms vary in terms of specifics and also the intensity. So there are those patients who are crippled by this, and the other end of the spectrum, there are those patients who are completely unaware of it. So when we're thinking about treating this, we're thinking about these two things: preventing unnecessary stroke and making people feel better. And that leads us to a variety of treatments that involve both medicines and surgical procedures to try to resolve the situation that we lay out for patients when we work through this problem. So there are really two different classes of procedures, each of which is intended to cure atrial fibrillation. And I like to think of this as an effort to wrap electrical tape around those frayed wires. They're both called ablation, but they're done in different ways. So there's the demarcation is catheter ablation is no cutting or suturing, using small ports, which are needles, as I mentioned. Surgical ablation is cutting and suturing. So coming between the ribs from one direction or another, sides or the front, in order to directly access the heart. What you get with that access is the ability to wrap more electrical tape. So more ablation, which correlates with better outcomes. So suffice it to say, for a subset of our patients, surgical ablation is the way to go. What we do with catheter ablation is we typically bring a patient in the morning of the procedure, bring them to a souped up room and lay them flat on a table and put them to sleep, so there's no pain or recollection. And then what we do is take little hollow needles about the size of a pen tip, put those needles into blood vessels that lie just beneath the skin of the groin creases on both sides. And through those hollow needles, we would thread wires up into the heart and either heat or freeze areas that tend to be regions of this fraying. Heating or freezing, extremes of temperature, cause heart tissue to die off and replace itself with inert tissue. So whereas electrically short-circuiting tissue was there before, now it's replaced with quiet tissue. So that would take between an hour and 2 hours, and then we would take everything out, send the patient back to where they first came in, and typically would send them home the same day. You know, we tell people that because of the anesthesia, they're not going to feel quite right for a day or two, beaten up for lack of a better term, but nothing to write home about. They can drive the next day unless they have a particularly physical job or occupation. What's happening at a level of the heart is recovering from the ablation procedure, so it goes through a process of healing, not unlike what you would see on your skin if you got a cut. So there's a period of scabbing, and then there's a period of slowly resolving so that eventually you don't see any evidence that the skin was damaged. And the patient can feel a variety of things, hopefully no more symptoms that had been associated with the atrial fibrillation. There are things that they might feel as a function of the procedure, so some chest discomfort related to the irritation from the procedure itself, issues with their voice because the anesthesia involves having a tube down into their windpipe so as to control their breathing, which goes through their vocal cords, some sore throat related to that as well. Discomfort related to the access sites in their groin area. These are the key things that patients tell us. So there's a small, but not zero, risk of stroke related to this procedure. We can also damage tissue that sits near the heart. So it's often said that nature abhors a vacuum. It's nowhere more true than with regard to human anatomy. So the heart is surrounded by organs tightly packed in there in the chest. And there are a couple of organs nearby that, if damaged, can cause some mayhem. One is your food pipe, we call the esophagus, sits right behind the heart. Damaging that can be very problematic. And then there are nerves that pass near the heart on their way to the diaphragm, which are the muscles that cause your lungs to billow in and out. Damaging those nerves would damage that function and will cause some problems with breathing. For patients that we would typically select for catheter ablation, from a single procedure about a year later, somewhere in the range of 7 out of 10 people will be free of atrial fibrillation, which means that 3 out of 10 will continue to have atrial fibrillation, maybe less than before, never more than before. But it is not a given that if you have this procedure, you will be cured of your atrial fibrillation. The principal goal is quality of life. Stroke is an issue as well, obviously, but we have other ways of dealing with stroke, for example, medicines. So we really focus in on, does it make you feel better? As physicians, we should be laser focused on 2 things, living longer or living better. This is not a living longer issue, happily. It's principally a living better issue.